today I'll be talking the failed back surgery syndrome. So the question comes, why it is failed back and what is actually failed? Is it the surgery that is failed or is it the back that is failed? So basically, what is a failed back surgery syndrome? So failed back surgery syndrome is a very non-specific term which simply says that the outcome of surgery for which the back surgery has been performed that did not meet the expectation. So before surgery, the goal set by the doctor as well as the goal set by the patient, they did not meet. That means it was expected a pain relief, it was expected a functional improvement, but still it persists. So this is one of the biggest challenge. And as I started with the question, what fails? Is the back fails or the surgery fails? Here both has the answers, because sometimes it is the back that fails. That means there are some recurrent causes that actually causing the pain, and sometimes definitely it's the surgery that has gone wrong, or its complication or its sequelae, whatever, that made the pain to persist, ultimately become the failed back surgery syndrome. Nowadays it is sometimes called post laminectomy syndrome, because when you saw it's a failed back surgery syndrome, it appears there is some problem in the surgery, but actually it is not. It is the situation that the patient and doctor falls when the surgery is not giving its expected outcome. Okay. Now, what are the causes of failed back surgery syndrome? Now, you should know that the best surgical outcome occurs when the right surgeon does the right surgery on the right patient at the right time. Now, among those four rights, if anyone goes wrong, then the patient may land up into the back pain, persisting back pain, and this is known as the failed back surgery syndrome. Now coming to the causes. So overall, we can say there could be possibility of the mismatch between the surgery needed and the surgery performed. For example, if there are two levels of the disc, sometimes you have already found that it is not always specifically you can say that exactly among these two levels which is causing pain. And now, frankly speaking, the concept of this diagnostic block, selective nerve root blocks, to find out which is actually the causative agent is not there. So what happened? Surgery has been performed. Now, which is the suspected level or the level which is the pain generator is not treated, rather other treatment is treated. So basically, there is a mismatch between the surgery required and the surgery performed. Then there could be possibility of incomplete evaluation or diagnosis. That means there could be a residual pathology. For example, the patient might have back pain because of two reasons. Okay, say it's because of herniated disc along with some facet problems is also present. Now, when one is treated, the remaining will remain, and ultimately the patient will be having pain for the remaining cause. Similarly, when the foramen is being cleared, if it is incomplete and some residual pathology remaining there, that could be also a cause of the failed back surgery syndrome. Then there could be a recurrent pathology. So when you have actually, say for herniated disc, you have removed the disc, but there is no guarantee that the recurrence will not occur. So there could be possibility of a recurrent pathology or a new pathology, maybe at the same level, maybe at a different level, ultimately giving to an outcome what is not expected. Then there could be possible complications of surgery. For example, there could be accidental spinal cord damage, there could be accidental nerve damage that is actually causing the problem. Then there could be situations that when the adjacent segments, for example, see this is a spine, and now because of some reason fixation is being done. Okay, say this two level fixation is being done. Now what happened after the fixation, that these two levels are not moving, but the adjacent segments, okay, they have to bear more load of the movement. Okay, when the patient is moving forward and behind, ultimately the above facet joint is getting more stress. So ultimately that may land up in a facet joint arthropathy sometimes. Sometimes there could be possibility that other type of injuries might occur. So basically it is the post arthrodesis adjacent segment degeneration. So these are all possibilities that can cause the failed back surgery syndrome. Let's move to the first point, that is when the mismatch between the surgery needed and mismatch between the surgery performed. So when a surgeon chooses an operation that is not appropriate for the structural problem, okay, or surgery did not address all the patient's pathology, then the patient may land up into such a situation when there could be persistent pain. Now coming to the next point, that is the incomplete evaluation and diagnosis. Basically, there could be a possible residual pathology. Now this residual pathology may be either a spinal pathology or it could be a extra spinal pathology. The spinal pathology example I have just given, but extra spinal pathology, for example, say the patient is having back pain radiating to the legs. So ultimately, when the patient is operated for the herniated disc, the sacroiliac pain that remained. So this could be called an extra spinal pathology. Okay. Then there could be residual or recurrent structural pathology, and there could be possibility of inadequate evaluation. Or surgeon fails to fully consider the effects of the surgery on the motion segment. That is also very important. That means when I am doing the surgery, I am focusing on the part that is causing the problem. But after removal of the part, how the dynamically, statically everything is fine. But when the patient will start his movement or her movement, then what will be the change during the movement that is not assessed. So that could be another possible cause of the failed back surgery syndrome. And the common rule is that long chronic back pain is associated with the illness, or I should say the psychological impairment is usually associated. For example, there could be sensitization, which could be a central sensitization, which could be causing lot of psychopathological problems, and ultimately because of them there could be possibility that the patient might land up in a failed back surgery syndrome even with a perfect surgery. So that is also a possibility. Then there could be failure because of recurrent pathology or a new pathology. So it is quite common, as I told, after fixation or even after surgery. Okay, so what happened is that the disc height is reduced. Now there was an herniated disc that was removed, but when the disc height is reduced, there will be more pressure over the facet joint. So this disc height, this is reduced. So here the loading over the facet will increase, and this will result in a facet syndrome. So this could be called a new pathology. So this is another cause for the failure, and this is another cause of the failed back surgery syndrome. Now coming to the complications. What could be the surgical complications that can not recognized during surgery later on can produce pain? For example, there could be possibility of the incidental durotomy, which is not recognized at the time of surgery. Ultimately that can lead to a pseudomeningocele. Then accidentally misplaced pedicle screws that can cause a new leg pain. So there could be possibility of these conditions. And there could be possibility of the intraoperative injury to the spinal cord and nerve roots. Okay, so see here the pedicle screw has gone much medial, and ultimately that can injure a nerve root or it can injure the spinal cord if it is at a higher level. Now coming to the intraoperative injury, again like this condition, there could be a pedicle screw failed, or even during the surgery there could be possibility of the nerve injuries, and ultimately which can lead to pain following the surgery. Now coming to the situation, see the picture. So there is a movement of the intra-body cage after its satisfactory placement. So what the surgery was done, then the placement was right. But then eventually this cage has failed back and patient land up in excruciating pain. So this could be another pathology, and this will also cause a failed back surgery syndrome. Next come to the post-arthrodesis adjacent segment degeneration. So as I told you just now, there could be a possibility that two segments we have put the screws, and now I am sure that from this segment, as there is no pressure over the disc, it is minimal and there is minimal movement, so chances are that the reherniation will not occur from there, or if it is a pars fracture, then the listhesis is corrected and it will not be there. But what could happen? See, this portion is fixed, so there is possibility that the adjacent segment might have to bear the additional load, and due to this additional load there could be a fracture here, there could be a facet arthrosis here, leading to again back pain for that patient. So that is why sometimes it is told even after back surgery the pain do not goes. So there are a lot of reasons for that. Now this is one of the study by the Leishman et al. There is a very long-term study with a follow-up of average 33 years, and 33 patients with lumbar fusions below L3 was followed. Now, radiographic evaluation is done with the flexion extension lumbar spine films as also as with the CT scan. It's an old study, so you can see it is a quite old study and old publication. So that time MRI was not that very available, so their evaluation was mostly with the X-ray and CT, and they have found that there is a quite high possibility of the adjacent segment degeneration and segment instability above the fused level, okay, which is occurred in 45% of the subjects, that is 15 out of 33, okay. And it has been found according to the level, 30% is having one level above, 12% is having in the second level above, and 15% of the patients is having in a level below the fusion. So there is a quite high possibility. And the similar study was done by Dutta et al., which has been found in a patient of 65 patients with lumbar fusion, and average follow-up, this is comparatively less, that is 39 months post-operative follow-up, and it has been found that the 24.6% patient having the post-fusion instability has been found, and it is most common in the level above fusion, and most common type instability they have found is the retrolisthesis. Now coming to the differential diagnosis and common causes of failed back surgery syndrome by symptoms, spine, signs, radiology, and what are the treatment options. So there could be possibility of the lateral canal stenosis, which can lead to the leg pain, which is more than the low back pain, and the patient usually gets some relief while sitting. And the signs, there could be possible loss of lumbar lordosis, and in MRI you have to find out the foraminal stenosis, and you can give relief, first of all definitely not by injections but by physiotherapy and exercises along with the medicines. It is not responding, you can go for the epidural steroid injections. There could be possibility of the persisting neuropathic pain, which could be burning dysesthesia in left or right pain. So there could be causes of central sensitization. Basically there could be hyperalgesia or allodynia, and here the management is mostly with the help of the medicines. Now coming to the, and definitely psychotherapy, CBT also helps here. Now painful discs, that could be possible because again of two reasons. One possibility is there could be an inflamed disc, that is the possible cause where there is the sensitization is increased, maybe because of the degenerated disc, or there could be possible of reherniation. Now there could be possibility of the facet pain, which could cause the facet tenderness. Here definitely we can go for the intra-articular facet diagnostic injection or median branch diagnostic injection followed by radiofrequency ablation. Now there is possibility of the recurrent nucleus pulposus herniation. There also in this condition the leg pain will be more than the back pain, and there could be possible that MRI could detect this situation, and ultimately you can go for the epidural steroid here as well. Sometimes it could be a sacroiliitis, that is the cause of the pain. So here you have to detect the sacroiliitis and go for the appropriate treatment. That is, first you have to go for the intra-sacroiliac joint steroid injection. If the patient is not responding or the response is short, you have to go for the facet denervation, sacroiliac joint denervation. So this is in a nutshell what you are going to do in the situations. So let's move to the next part, that what are the structures that could be the etiology of the failed back surgery syndrome. As I discussed, lateral canal stenosis could be one, painful disc could be one because of the discogenic pain. There could be possibility of the disc herniation, there could be possibility of the facet joint pain, there could be possibility of the sacroiliac joint pain, there could be possibility of the epidural fibrosis or adhesions. So these are the common causes of the pain following the surgery. Remember, among these, some causes can occur even before surgery, like the others like the facet, disc herniation, sacroiliitis. So you have to first think of that before surgery whether they are present with the primary pathology or not. Then it becomes much easy. You have to treat it accordingly. Now coming to the radiological evaluation in a case of failed back surgery syndrome. Radiological evaluation usually includes X-rays, MRI and CT scan. Truly speaking, nowadays definitely except for the bony abnormalities, we prefer the MRI most. And in rare situations when you are not sure about the diagnosis, and in situations where there could be possibility of the infection or inflammation, you can go for the radionuclide scanning. Okay, so in case of possible spondyloarthropathy, possible infection, possible malignancies, you have to go for the scan. Next come to the myelography, which can be done for the pseudomeningocele. So these are in a nutshell the common radiological examinations that you have to do in a case of Feldback surgery syndrome. Next move the rule of the standard radiograph. So in standard radiograph can show you the alignment, can show you the extent of disc space narrowing, it can show whether the spondylolisthesis is present or not, it can show whether there is pseudoarthrosis present or not. So these informations we can get from a standard radiograph. Next, coming to the MRI, definitely MRI is one of the most important investigations that we commonly do even in case of Feldback surgery syndrome. Now, it visualizes the both foraminal zones, and to avoid missing foraminal or extraforaminal pathology, MRI is basically the best, and it can help to visualize the central canal and structural relationship with nearby structures that changes to the neural elements. Now, MRI is an excellent study for the spinal stenosis. It can detect hypertrophy of the facet joints. It can detect ligamentum flavum pathologies, hypertrophies. It can detect synovial cyst or prominence of epidural fat. It shows if the decompression is adequate or not. Okay, and there is always a question whether MRI can be done after the instrumentation or not. Remember, for the older patients, they have gone surgery earlier. We are very skeptical because there could be possibility of a implant with a ferromagnetic substance. But nowadays, as they are mostly titanium alloys, so you can do MRI in most of the cases nowadays. Now coming to the contrast enhanced MRI. Why it is required? Especially in such a conditions when there is epidural fibrosis, this contrast enhanced MRI can help you to distinguish between the peridural fibrosis and disc herniation. Sagittal and axial T1 weighted imaging with contrast effectively evaluates the postoperative lumbar spine after 6 weeks of surgery. And remember, the best time for the highest enhancement with the contrast is less than 9 months postoperative, and minimal enhancement is seen after 1 year. So the best time is within 9 months. You have to 6 weeks to 9 months. You have to check whether the adhesions are present or peridural fibrosis are present or not. Now coming to the post contrast enhancement, you can see in this area there are increased uptake. Okay, so there could be possibility that here there is the dural fibrosis has occurred, and that is actually these adhesions are causing again pain for the patient. Now here there is a difference in a 52-year-old woman 1 year after surgery of the L5S1 disc herniation. So see, here it is very difficult to understand whether it is the disc or it is the epidural fibrosis, peridural fibrosis. So here contrast enhancement is showing, so it could be possibility of a fibrosis here. Now, should I go on searching as long as I am not getting the pathology? Answer is, every time it is not possible to find out the pathology with the investigation. So you have to go for the diagnostic interventions. Now, among the diagnostic interventions, if we are suspecting a facet joint block, a facet joint arthropathy, we can go for a facet joint block to find out whether the facet is painful or not, or you can go for with the medial branch block as well. If we are suspecting a sacroiliac pathology causing the pain, we have to go for the sacroiliac joint injection for the diagnosis, and later we can go for the multiple steroid injections, or you can go for the denervation. If there is a foraminal stenosis, then we can initially go for the epidural steroid injections. If it is not responding, we can sometimes go for the resurgery. In certain situations, we have to go for the epidurography or epiduroscopy, and if there is adhesions, it can be broken with the help of epiduroscopy or with the help of the Rax catheter. So ultimately, this diagnostic block helps to find out the pathology from where the pain is coming. Now coming to the treatment. Remember, initial treatment is always conservative. That means physical therapy, medication. That is the first thing that you should do. If it is not responding, you can go for the interventional procedures. Even if it is not responding, you can go for the surgery. So these are the things you have to follow even in case of the Feldback surgery syndrome. Now these are the common interventions for facetic arthropathy. we can go for the radiofrequency ablation. For epidural fibrosis, we can go for the adhesiolysis. For epidural steroid injection, we can go deep in the disc disruption or herniation or spinal stenosis. Neuromodulatory therapies like spinal cord stimulation can be given in resistant cases. Remember, this is one of the, I should say, intervention that is having highest evidence in case of failed back surgery syndrome. Okay, so we should consider SCS when the other modalities have failed, the patient is still having pain. So I think you understood what is failed back surgery syndrome, what are the causes, how to investigate and how to manage. Thank you for the nice listening.